The purpose of this presentation is to provide a systematic approach to dressing selection with a holistic, patient-centered perspective. This presentation will outline the process involved in selecting a dressing for a chronic wound.
This will begin with obtaining a history, conducting patient assessments, and establishment of wound etiology. We will be discussing the integral elements to consider when selecting a dressing, including infection, exudate management, depth, location, and additional patient factors. Finally, we will be discussing the existing evidence within the literature to support the use of these dressings for chronic wound management.
Obtaining a thorough history is the first and most important step in gaining a holistic understanding of the precipitating factors leading to ulcer formation. This enables the clinician to identify potential limitations to healing. Upon obtaining a thorough history, several key assessments must be undertaken in order to identify the etiology of the wound and its potential for healing so that effective treatment aims may be established. Etiologies of wounds can involve ischemia, neuropathy, venous pathology, pressure, or a combination. Venous ulcers are often found at the gaiter region close to the malleolus, and they are shallow wounds which have a high amount of exudate. Comparatively, arterial ulcers can be found anywhere on the lower leg, are typically dry, and often look punched out in appearance. Additionally, neuropathic ulcers are found on weight-bearing areas of the foot or where trauma from footwear can occur. These are usually dry with a small amount of slough and occasionally bleed. The key assessments include dermatological, biomechanical, neurological, and vascular. The management plan will be established taking into account the patient's preferences. Following cleansing and debridement of the wound bed characteristics must be evaluated in order to select the appropriate dressing that promotes the optimal environment for healing.
The following wound bed characteristics must be addressed when selecting an appropriate dressing for the patient, including infection, level of exudate, depth and location of the wound, and additional patient factors. Wounds are often colonized with a stable bacterial population. However, an increased bacterial load is associated with a prolonged rate of healing. Characteristics of infection include, but are not limited to, yellowish-grey wound base, purulent exudate, malodor, delayed healing accompanied with pain, erythema, and heat. The most common microorganisms are gram-positive staphylococci and streptococci. However, chronic wound infections are often polymicrobial. Topical antimicrobial dressings as primary dressings combined with systemic antimicrobial therapy may assist in the reduction of bacterial load and protect the wound from further contamination. In addition, topical antimicrobial therapies do not drive the increasing prevalence of antimicrobial resistance, as they provide high local concentration without penetrating intact skin or into deeper soft tissue. Furthermore, topical antimicrobial therapies may be beneficial in patients with compromised vascular supply. Evidence behind the use of topical antimicrobials is limited due to the insufficient, well-designed clinical trials. The most commonly employed topical antimicrobial dressings are available in various preparations. These include manuka honey, cadexima iodine, and silver. Several patient contraindications against the use of iodine-based antimicrobials include allergies to iodine, hypothyroidism, pregnancy, and breastfeeding. In addition, the level of exudate will ultimately dictate the most suitable preparation for the patient.
Moisture balance within the wound bed is integral to healing. Through the selection of a wound dressing, the aim is to prevent maceration or desiccation. It is important to note that due to the dynamic nature of the wound characteristics often change throughout the healing process, and this may impact the level of exudate production. Therefore, it is imperative for the clinician to monitor the wound and ensure that a moist wound environment is maintained by adjusting wound dressing selection accordingly throughout the wound healing process. For a dry wound with eschar formation, achieving moisture balance through rehydration and facilitation of autolytic debridement are the main aims of treatment. One option to achieve this is an amorphous hydrogel combined with a polyurethane film dressing. Hydrogel dressings consist of up to 96% water and are designed to rehydrate the wound and assist in debridement. Examples include intrasite gel and solosite gel. Film dressings are permeable to water vapor and oxygen, but not to water or microorganisms. Examples include Tegaderm and Opsite. In contrary, for a dry wound within its final stage of healing, treatment aims may include continuing to maintain moisture balance and protection of the wound. Numerous primary dressings exist that can be used to achieve this. These include thin hydrocolloids and film dressings. When in contact with the wound surface, hydrocolloid dressings form a gel to provide a moist wound environment. Examples include Duoderm and Replicare. For a low exudating wound, the treatment aim is to maintain moisture balance to promote granulation and epithelialization. In order to achieve this, there are several suitable dressings available, including an amorphous hydrogel as a primary dressing combined with a secondary film dressing, or alternatively a hydrocolloid dressing may be used as a sole primary dressing. For a moderate exudating wound, the treatment aim is to achieve moisture balance through the removal of excessive exudate to facilitate granulation and epithelialization. In order to achieve this, several options are available as primary dressings. These include hydrogel, hydrocolloid, alginate, silicone, and foam dressings. When placed into the wound in a dry form, alginate absorbs exudate to form a hydrophilic gel to maintain a moist wound interface. Examples include Algicite M and Acticoat, a silver alginate dressing. Foam dressings characteristically contain hydrophilic polyurethane, although some include additional absorbent materials. These dressings are efficient at absorbing high levels of wound exudate. Examples include the Alleven range, Alleven Silver range, Acticoat foam, and Cavicare. For a highly exudating wound, the treatment aim is to achieve moisture balance through removal of excessive exudate. Primary dressing options include alginate and foam dressings. Either of these may be combined with the retention bandage or polyurethane film dressing as a secondary dressing. It is important to note that occlusive bandages should be avoided, as these may cause maceration.
In addition, the conformability, size and shape of the dressing must be considered to maximize its effectiveness. If the dressing does not conform to the wound, for example, if the dressing does not fill the dead space of the wound, the beneficial properties of the dressing may be lost and the dressing may be rendered ineffective. As previously discussed, the ever-evolving nature of the wound will dictate the type of dressing and the frequency of dressing changes. For example, Wounds International asserts that an infected, highly exudating wound requires daily dressing changes initially, then every 2 to 3 days thereafter once the microbial burden has reduced. Additionally, this will also depend on the type of wound and its associated characteristics.
It is essential to adopt a holistic approach when making a dressing selection. The gold standard treatment will be explained to the patient, however patient preferences ultimately dictate dressing selection. Several additional factors should be considered to optimize compliance and healing. First and foremost, the projected cost of dressing should be discussed and agreed upon with the patient. If the patient is unable to afford the recommended dressing, this may result in non-compliance and poor patient outcomes. Furthermore, the comfort of the dressing must be considered. If the dressing causes irritation, for example, the patient may develop a contact allergy from the adhesive, this may result in non-compliance and poorer patient outcomes. Additionally, if the patient has compromised skin integrity, ideally the dressing must not cause iatrogenic injury. Also, healthcare access may be a limiting factor when selecting a dressing for the individual. This may be overcome by selecting dressings that are easy for the patient to apply and remove between access to healthcare services. Finally, if the patient considers the dressing to be aesthetically undesirable or negatively impacts activities of daily living, this may reduce compliance.
Systematic reviews by Chaby et al. And Boozer, Munoz, and Amate have failed to demonstrate significant benefits of advanced wound dressings over conventional gauze in the management of chronic wounds. This is with the exception of hydrocolloids that have been found to improve healing rates of leg ulcers and pressure sores when compared to paraffin gauze. This was shown in 3 systematic reviews by Bradley et al., Singh et al., and Boozer et al. The lack of evidence surrounding advanced dressings may be due to the lack of consistency between studies and poor study design, including the lack of blinding and randomization. The paucity of evidence needs to be considered in conjunction with the accepted superiority of moist wound healing and expert opinion, which is in favour of advanced wound dressings. For example, the Wound International Diabetic Foot Infection Practice Guidelines recommends the use of advanced wound dressings in management of chronic wounds. We hope that this presentation has provided you with an insight into the process of selecting a dressing when managing a patient with a chronic wound. Thank you.